home region. So to tell you frankly, his father fell sick and he had to take him to the hospital in the morning. So we'll talk about hamstring also. It is very commonly done procedure, but we can entertain question and we can discuss about that. So without further ado, I hand the stage to Vivek, who is going to coordinate and what we are going to do in this program today. Okay, over to you, Vivek.
Thank you, sir.
Vivek, can you request everybody to mute until unless they are required to speak? All of us, let us mute ourselves so that whenever you need to speak, you unmute and speak. That will create less. Dr. Prakash, Dr. Mahesh Karmacharya, yeah. Please keep yourself muted. Yeah, Vivek, go ahead.
Thank you, sir. Respected colleagues and seniors, today we are going to discuss we have discussed about basics arthroscopy and advanced arthroscopy. Today we are going to discuss about the graft harvest technique, which is very important for us arthroscopists. So welcome all. Today we are going to discuss about the graft harvest technique. For teaching us, our faculties today will be Professor Arjun Lamisani, Professor Amit Joshi, Dr. Sailaj Ranjitkar, and Dr. Vibhuti Nath Mishra. Because of some family reasons, Sailaj sir won't be there, but we will entertain questions on graft hamstring harvest as well, because hamstring is very important graft. And so I want to discuss something about basic.
Vivek, तिम्रो स्लाइड्सहरु देखिरा छैन विवेक? यो खाली माथि वेलकम टु ASON वेब सिरिज भनेर देखिरा छ.
Is it? अहिले देखिया छ सर?
छैन.
No?
माथिको मात्रै देखिरा छ. त्यो सानै गरेर देखाउ, सानैमा देखिरा थियो.
Okay. So graft harvest started from first IT band. Later on, quadriceps was tried, and after that BPTB came into picture. Then hamstring came into picture and it became famous for some time. And new kid in the block is peroneus longus. So today we'll be discussing about all these grafts except the IT band. And there are multiple grafts. The grafts should be strong, readily available for ideal graft, and there should be minimal graft site morbidity. And these graft, after inserting into the knee, should allow aggressive rehab. But as such, there is no ideal graft till today. The decision making depends on various factors: the patient's age, the activity level of the patient, associated injuries, availability of various graft materials, and surgeon's comfort level. After the graft is inserted into knee, the graft goes through various stages of ligamentization. I think this will be discussed by our faculties. And immediately after graft insertion, the strength of the graft decreases massively. So the graft which has to replace the normal graft should have more tensile strength than the normal native graft. So these all BTB, bone patellar tendon bone graft, semitendinosus, and quadriceps, and even the peroneus has ultimate tensile strength which are stronger than the native ACL graft. So even if the strength of these graft after insertion decreases, this is not less than the native ACL graft. So let's learn something together from our esteemed panelists. And I would like to request Professor Arjun Lamisani to share his screen and he will be talking about bone patellar tendon bone graft. And I would like to request my dear colleague, the new upcoming arthroscopy surgeon Naveen Tripathi, to co-host me. Sir, all yours, sir. Sir, हजुरको दुईटा डिभाइस अन छ जस्तो छ सर, इको आइरहेछ.
दुईटा छ.
एउटामा म्युट गर्नु नि सर.
म्युट गरेछ.
इको आइरहेछ.
अनि यहाँ त छैन. अनि यसलाई ओके यता जस्ट Okay, सुरु गरौँ.
Yes, sir.
Okay, good morning, everybody. Thank you, Scientific Committee of Arthroscopic Society of Nepal, for giving me this opportunity to talk on harvesting technique of bone patellar tendon bone graft. This bone patellar tendon bone graft is said to be a gold standard for the ACL graft because all successive graft options have been compared with the different characteristic of bone tendon autograft. Historically, the bone patellar tendon bone graft has been the most common and extensively studied autogenous graft used in ACL reconstruction. There are pros and cons of this bone patellar tendon bone graft. It is said to be a gold standard, as I mentioned. It has got an early incorporation of the graft is because of bone-to-bone healing. And its tensile strength is guaranteed, like it's around 2,915. So
Arjun sir,
the fixation, yes,
sir, सर हजुरको
Yes.
यो स्लाइड उसको भ्यूमा आइरहेछ सर, प्रेजेन्टेसन मोडमा आइरहेछ, यो पुरै स्क्रिन डिस्प्ले भएको छैन सर। प्रेजेन्टर भ्यूमा गर्नु,
हजुर
प्रेजेन्टर भ्यू वालामा आइरहेछ सर, तपाईको नेक्स्ट स्लाइड पनि देखिरहेछ, पुरै भ्यू देखिरहेको छैन सर, होल स्क्रिन आइरहेछ,
पुरै देखिया छैन।
हजुर
स्क्रिन आएको छैन,
अहिले ठिक छ,
हाइट हजुर अहिले ठिक छ।
Okay. And the fixation is also excellent with the help of interference screw, and sometimes can be aided with other technique also. There are some cons like anti-knee pain and a degenerative joint disease. Anti-knee pain has been found in 17 to 57% in different studies because it has got a large incision. So cosmetically also many people, they do not like. There is always risk of some patellar fracture and patellar tendon rupture also. The morbidity was the major drawback. So other choices were looked for, like fracture of patella, and there is anti-knee pain and long skin scar. There are steps of harvesting bone patellar tendon bone autograft. You got to evaluate the patient first, and harvesting, preparation, and closure of the harvested wound. Most important part is patient selection and evaluation. The ideal patient could be when the patient need to go into prompt return to play is required. In athletes who need dominant hamstring actions like sprinting sports like basketball and volleyball also. In patients, those who are not compliant with rehabilitation and reconstructions, restriction of activities which are instructed post-operatively. If on examination that reveals hyperextension of the knee, it is a bit controversial because most of the people agree that the reconstructed knee also should have the same range of movement of opposite side in order to have same in order to gain the same gait pattern. We have to look for whether there is a previous patellar fracture, patellar tendon injuries. If there is a history of anti-knee pain or any patellar problems, this should also be excluded. Then I'll be talking on the technique of harvesting the graft. Now, first of all, we should identify the lower pole of the patella and the tibial tuberosity. The incision is about 6 to 8 centimeters from the lower pole of the patella to the about 1 to 2 centimeters distal to tibial tuberosity. And with the skin and subcutaneous incision, we have to go down to the level of paratenon. Then after identifying the medial and lateral extent and the proximal and superior extent of the patellar tendon, then we have to incise the this paratenon longitudinally because it is important to identify this inside separated because it is the source of blood supply to the tendon, and that need to be closed so that even the tendon will also be formed from the paratenon. Then after separation of the paratenon, we have to measure the width of patellar tendon. Most of the time it is about 3 centimeters, and the middle 1/3 or the 1 centimeter is taken 10 millimeter, and it is marking is done. After this, so with the help of the 10 or 15 size knife, the patellar tendon is incised longitudinally from superior to inferior. Even up to the major part of the tubal tuberosity and patellar tendon should also be incised with this periosteum is inside with the knife, so that it will be easier to do osteotomy. And during this insertion and incision, the tendon should be kept in retention. Our aim is to make the bone block by 2.5 centimeter by 1 centimeter in the patellar side, and about 2 to 2.5 centimeter by 1 centimeter in the tibial side. With the help of 10 millimeter oscillating saw, we have to do osteotomy mostly from the tibial side, or you can do from either side. But if you are not using a tourniquet, it is better to start from the tibial side, because if you do on the patellar side first, there will be bleeding and will have disturbances and osteotomy also. We have to take care the angle to cut approximately about 45 degrees from either side toward the midline while cutting medial and lateral part in order to make this bone plug a trapezoidal shape. And also it limits the resection depth up to 7 to 8 millimeter. And we should avoid overcutting of the bone, especially in the patellar side. And make 2 suture passer cortical drill holes on the patellar bone block. Because what I do is I do put this bone patellar side toward the tibial tunnel, and the single or double suture passer drill hole on the tibial side. So this is going to be put on the femoral tunnel. This hole should be made close to its end for the better directional control. Then remove the bone plug from their donor side with the help of 10 millimeter cup osteotome. You should be careful during this making this osteotomized bone plug disengaged from the trough. In that condition, you should avoid laboring the osteotome against the underlying bone, because it can lead to the fracture. This is after removal of the bone plug from the patellar side. And after this, the extra bones should be trimmed, and they should be contoured the end into the blunt tip with the ranger to aid passage through the tibial through the tunnels. And we should put number 5 polyester sutures through the holes, and 2 on the tibial and 1 on the medial side, femoral side, like shown here. Then after this, it should measure the overall length of the bone plug and of the tendon portion of the harvested graft in order to plan the length of the tunnels and fixation device. Size the bone tendon bone graft so that it passes snugly easily through the 10 millimeter sizer. Some would like to make this femoral side bone plug 9 millimeters so that it can be passes easily. And you should check whether it freely passes through the 10 millimeter tunnel or not. It is better to put some remaining excess bone graft into the patellar harvest side. In different studies, it has been said that it also decreases the chance of entry knee pain if you graft the harvested top side, donor side. The only peritoneal tendon should be closed. Then I'd like to show you video. This has been some video has been taken from other sources also. This is not all my video. This is the skin incision from the lower pole of the patella, longitudinal, more on the medial side. And so that this medial side placement of the incision, one is that decrease the chance of entry knee pain during kneeling because it lies more medially. And this same incision can be used for the purpose of tibial tunnel making also. Then you have to go up to the level of the tendon, then identify the medial and lateral extent of the tendons. Even superior and inferior should also be identified. The extent should also be identified. And then the paratendon should be incised longitudinally. Then you separate this paratendon from the tendon, superior to inferior and medial and lateral side, and so that it will identify the exact extent of the patellar tendon. So it will be easier for you to do marking and planning. And this paratendon should be repaired later on, so that the meticulous dissection is needed. Then marking is done, and 1 centimeter, 10 millimeter middle third of the patellar tendon is incised longitudinally on the medial and lateral at the measurement, and from lower pole of patella to the tibial tuberosity. Then even the periosteum of the tibial tuberosity should also be incised with the knife. And this osteotomy should be done with a small saw having high RPM, so that there is less chance of having deflection. And medial, lateral, then at the last, the distal end of the tubular tuberosity bone block side should be done. Then here, with the help of a small osteotome, this should be disengaged from the host bone. Once it is disengaged, it is easier to make a drill. In this situation, putting on the trough, you can either make a 1 or 2 drill bit. I usually make a 1 drill bit on the tibial side that is going to be inserted on the femoral side. And likewise, the patellar part of the bone plug is also major was to this periosteum is incised. Medial, lateral, then the superior. During this process, it is better to maintain the tension of the patellar tendon. Then medially and laterally with a 45-degree angle. And the superiorly also, this should be of 30 to 45 degree. So trapezoidal bone block can be made, and we do avoid injuring the cartilage part of the articular surface of the patella. Once it is disengaged, and this is also drill with 2 millimeter drill. Okay, this is after removal. Okay, thank you.
Hello.
Sir, please unshare your screen, sir.
Okay, okay.
मोडरेटरहरू आइहाल्यो न सकिएपछि चुप्लाएर बसिरहन्छ
So, thank you, Arjun sir. That was very wonderful presentation. We have few questions from our chat box. First question is from Naveen Kumar Karan sir. Any experience of using two transverse incision, that is minimal invasive graft harvest technique, or curvilinear incision to reduce the anterior pain? His question, sir. Arjun sir.
I have no experience. I do give longitudinal transverse incision on the medial side. If you keep it away from the midline, that also helps to decrease the anterior pain.
Okay. Any experience with two transverse incisions, sir? That is new.
No, I have not used.
Okay.
Can I add just one question here, Vivek?
Yes, sir, please.
Dr. Arjun,
Yeah.
one of the hesitant part for me personally, using a BPTB is the incision is, when you make the skin incision, it is, as you said, also, quite long. I rarely do BPTB. I want to ask, like, if you go on doing a longitudinal incision with experience, can this be the length of the incision you make to harvest the graft can be decreased? What do you feel? Like you should have a good exposure to have a good graft, or you can say that with experience you can shorten the length of incision you give, so that you can get away with, it's a very well known complication, I mean, like, disadvantage of BPTB, that making a long incision. What do you think, that you can improve with experience, or to have a good exposure, adequate length of incision to take out the graft?
Initially, you have to make a good long incision so that you can expose it well. But in due course of time, once you become more experienced, then you can decrease the length of the skin incision, and you dissect subcutaneously so that you can pull the skin up and down. Even you can pull the skin up by making the knee straight also, so that you can take that incision part to proximally and distally also, so that even with a smaller incision, you can take the graft out. You are right, Dr. Sir.
Thank you.
Next question is from Amit sir. Sir, many of our places do not have a small saw, what you have shown in your video. What do you recommend in such condition when the institution do not have small saws?
Another option is if you have a sharp osteotome, that also works to some extent. And before that, what you can do, you can make a multiple drill along the line of osteotomy, and then you can inside other do osteotomy with the sharp osteotome also. If you have thin sharp osteotome, it also works.
What is the size
I've
of
done
the
in a few sometime. Pardon?
Before you take out with the osteotome, you said you make drill holes. I think that is good. Yeah, that is always a technique when you do any kind of osteotome with a osteotome. What is the size of the drill bit with which you make that hole in the tibial bone plug? The size of the drill bit. What do you recommend? The size of the drill bit in the bone plug, in the tibia, in the graft, tibial bone plug.
In order to do osteotomy, or in order to
No, you have taken out the tibial bone plug.
Yeah.
And you said you make a hole there. What is the size of the drill bit?
Usually 1.6 or 2 millimeter.
So 2 millimeter is like, you can make that hole with a K-wire also, 2 millimeter K-wire, or?
Yeah, K-wire, K-wire.
Okay.
Because it is smooth and less chance to cause more like injury.
Okay, thanks.
So in continuation with Ishwar sir's question, do you use pre-drill the margins of the osteotomy with K-wires when using saw, or you have to pre-drill only when we use osteotomy, sir?
I do not pre-drill if I'm using osteotomy. Okay, I mean a saw. If it is only an osteotomy.
Okay. And another question is from Dr. Susan Paudel from SIR Memorial. His question is, which end of the graft should be kept on femoral or tibial side? Is there any compulsion or it can be interchangeable?
It also depends upon, I think, surgeon to surgeon, but my opinion is and also I have seen in other surgeons doing also, is if you put this tibial side toward the femoral tunnel, you can have a more clear space while putting the screw, and so that there is a less chance to cause injury to the tendon.
Sir, will you please?
Because this attachment of tibial this patellar tendon is anterior. Okay.
Okay.
You are taking a plug, tibial bone plug, and you are rotating anteriorly.
Okay.
The deeper part will be put anteriorly, so that the attachment of patellar tendon will be away from the bone, so that you can have some clear space while putting the screw, so there is a less chance to cause injury to patellar tendon or the graft.
Okay. Is there anything like strength of the bone from the tibial side or the patellar side that matters in decision making, sir?
No, I didn't have idea.
Okay.
Vivek,
So,
can I just because I am also doing bone tendon bone some more maximum is the hamstring. Earlier, exactly what Arjun Dai has shown, I also used to do the same way, to take a maybe 9 to 10 centimeter incision in the midline and like that. Over a period, then the three important problem came. One is the anterior knee pain, another was double bundle, and the third was the transtaportal. Then I shifted to the hamstring. But still in some of the cases, I still do bone tendon bone, maybe laborer or the poor patients, where the graft harvesting technique I have revised a little bit, that I just want to share. That the incision usually is a very maybe 3 to 4 centimeter incision only I give, is a sort of oblique curvilinear sort of incision, and that is made at the around 10 to 15 degree flexion of the knee, and with the just pulling the skin upward and downward. On that basis, I make a drill hole in the patella as well as the tibial tuberosity, and while making an incision in the tendon part, I again hyperflex, so that the incision over the tendon should be sharp. So that is one modification I do. Besides that, the earlier I also used to use this patella on the, I used to reverse tibial tuberosity graft on the femoral side and the patella towards the this tibial side. But nowadays I take a little bit longer graft on the tibial side, similar to the tongue shaped. The advantage what I got there is the when there is a mismatch of the tunnel graft mismatch, then if it is a very long, then a part of the bone is coming out for the tibia. So we just to the saw trim it, and it is balanced. So nowadays I do tibia on the tibial side and the patella on the patellar side. That difference I felt, so I want to share it. That's all.
Okay. Thank you, sir.
Okay, yes.
That was a very good suggestion from Tara. Let's be precise because we have limited time, I know. अलिकति यो अरूहरुको क्वेशन पनि सुनिदिनु पर्यो because there are a lot of other participants, हैन. We expert, we know how to manage all the things, but there are younger colleagues who are asking questions. Probably you have to take those questions also, Vivek.
Dr. Nagmani, please come in for your question.
Well, Arjun sir mentioned two things. One, I wanted to know that you can harvest bone patellar tendon bone graft either from the central third or the medial 1/3. So how often
medial,
do you do?
Not medial 1/3, middle 1/3.
Yeah, that's what, sir. Medial 1/3. Medial 1/3.
No, middle.
Have
middle.
you middle or central? So
Central
there is
or
another
middle.
Oh, okay. Oh, that is middle, sir. But it has been reported in literature that medial 1/3 can also be used, sir. And have any one of you tried? Because medial 1/3 has been said technically to be more better than central 1/3. Reason being that your healing of the tendon substances on either side of the central 1/3 is less, and the chances of intrapatellar contracture syndrome is higher, sir. So any problem with the healing which you have expected?
Patellofemoral contact stress also, like patellofemoral contact point can be changed if you take from the medial third only.
Well, that's what my question is, sir, because it's in the literature. Do you see any problem with the central 1/3 when you are harvesting with the healing of the remaining part of the tendon or any contractures which you see, sir, in the long run?
The contracture I have not seen. I also do these days in very selective cases. Most of the time I do use hamstring tendon. So I have not seen that problem.
So
Thank
next
you.
question is, there is another
Let me
question.
add, Vivek, let me add a small thing what Nagmani was saying. If you understand patellar tendon, this is not the thickness of the patellar tendon is not equal in all the directions. You know, it is more thicker at the center and it tapers down as you go into the lateral side. So you should not be on the lateral side. So that to achieve a thick BPTB, you should not go on the either side. You cannot go too medial. You cannot go too lateral. You become little more towards the medial side because of the more strength of the patellar tendon is on the lateral side. Because if someone who is normal valgoid knee or normal valgus knee, lateral part is body force hone hunale, so you spare the lateral side and be more towards the medial side, but it has to be the center. Okay, so go ahead. That is the question. I have something to say about, but let's finish the questions and then we'll come back.
Another question is from, I don't know, it's written resident over here. Is there any special technique for graft passes over the graft, like we do whip stitch in semi-T graft, sir?
I didn't get. Vivek, would you repeat it?
In bone blocks, you pass sutures, the pulling sutures you pass, right, sir? Is there any special technique or we just pass it?
While passing, one thing is you better make a smaller bone plug on the femoral side. Most of the authors say about 2 millimeter, 2 centimeter is good.
Excuse me, sir. Question is there any special technique of passing of suture, the pulling sutures we pass through those holes in the bone plug? Is there any special techniques mentioned?
No, I didn't get that point.
So you make holes in the bone plugs, right, sir?
Oh,
and
okay,
we pass the suture through those bone plugs so that we can pull those grafts. So are there any special techniques of suture placement into those bone plugs? This is the question, sir.
You mean anteroposterior or medial lateral or so?
Whatever, sir. Are there any special
technique you do?
I do use the anteroposterior, but many some surgeons, they would like to put medial lateral so that the thread will not be caught during fixation with the screw.
Yes, exactly. The concern with placing the holes in only side and passing the threads from only side is sometimes while pulling strongly, you may have caught through these threads. Have you had any experience with such things, sir? Placing
no, I do use only this anteroposterior only through the cortex.
Okay, so only one side. Though we can use one hole from one side and another hole from another side.
Some people drill three hole also. Some people like I have it.
Okay.
Vivek, there is one question we kind of left out. Somebody, Sanjeev has asked, has anyone ever used suspensory fixation for BPTV graft?
Oh, sorry, Sanjeev, I overlooked.
No, I have not used.
Has anybody used suspensory fixation of BPTB graft? Is that possible?
Naveen sir, Rajiv sir, Amit sir, Chandra sir.
There are techniques published. Oh my God, who is this? There are technique published in arthroscopy technique, how to use a suspensory fixation, fixed loop as well as variable loop, adjustable and variable loop. But I have never used it. For me, a BPTB is a bilateral interference screw fixation.
So the standard is there, but if you want to use it, you can use it, and there are techniques described. Okay. Yeah, Vivek, the last three questions. Carry on, please.
The question is from Sushil Sharma. Do you ever have experience of patella fracture or tibial tuberosity fracture or cartilage injury while harvesting the graft, sir?
No, not it, Vivek. I have not noticed.
So
can I just take over, Vivek? I want to put these two last questions. That's same. What Rajiv has asked also, as well as Sushil. The having a fracture in patella after graft taking is a very well-known complication. Since Arjun, Dr. Arjun, you do both techniques, you were doing BPTB. Which one do you feel confident? Like, did you left doing BPTB because you felt more confident with hamstring, or because everybody was doing it? Because you have had that experience. This is a personal experience. You just tell us. If you had
I felt easy, confident on hamstring these days.
Okay, thank you. So the question is asked, there are chances of having fracture in the patella as well as the tuberosity of the fracture. And what are the safety precautions you would like, you would recommend to us, to the younger guys?
Okay, for that, while doing a longitudinal osteotomy, you have to make the angle of about 30 to 45 degree toward the midline, and so that the osteotomy direction will be congruent. And while doing osteotomy in the superior and inferior most part of the this patellar and tibial tuberosity, here also you have to slant by 45 degree, and so that decrease the stage riser effect.
Okay. And carrying on with that same question, Sushil has asked that what is the purpose of trapezoidal bone plug in patella and rectangular? I think you kind of is there any purpose of making it sure that it is trapezoidal or not? No, I don't think so.
Basically, to do osteotomy to avoid
going deeper.
You
make a 45-degree angle, so the lateral and the medial osteotome meets above the cartilage, and you do not go into the deep depth of the bone, so that you avoid fractures. And later on, when the bone plug doesn't fit your size, you can trim it off, isn't it, Dr. Arjun?
Yeah.
Okay, Amit, do you want to put anything there?
Yeah. I just want to probably try to summarize our experience, and by saying that there is no doubt BPTP is a good graft, but there are problems associated with the BPTP graft. It is not only the anterior knee pain. If you go to literature, current literature, you identify that the incidence of anterior knee pain with the hamstring graft and with the BPTP graft, the current literature, they say that they are almost same. So probably the anterior knee pain is out of question. Why this is anterior knee pain is true because of two reasons. Because earlier we used to put right mid noise. So earlier we used to give a midline incision, which is right at the bearing area, and then second one is the second cause is we used to use a osteotome, the blunt osteotome. So when you harvest the BPTB from the patellar side in knee extension, your patella is sitting right over the femoral condyle. And when you use your hammer and the osteotome, there is going to be a cartilage injury, and probably that is the reason. And because of the use of this good size saw, small saw, sharp saw, the anterior knee pain is almost out of question, and nobody talks about anterior knee pain at this moment. But BPTV has its inherent problem because the harvesting technique is difficult. Not only the harvesting technique, its use is very difficult. How to use it when it is oversized or when it is undersized, the length mismatch between the tunnel, and this is a very challenging task. That is the reason why many people are coming out of, not because this is not a good graft, coming out because the management of the graft is really challenging. It's not that easy. Those people who are doing will agree with me that most of the time these are bigger one and you have to cut it. I don't know what to do it. And or if it is a small one, you don't know either it is having a good purchase or not. And the second thing is a fixation device. Most of the time in BPTB, the ideal fixation device is the interference screw, and that too a metallic interference screw. And there are a lot of study which is saying that probably PEEK and the biodegradable screws are not good for BPTB fixation interference screw. And then we all know that the possibility of the revision and the complication associated with the future possibility of the titanium screw, these are the things. But still we should not discard it. Probably in our context over last 3 years, we have our use of BPTV has increased in selected cases. But for the students and for the younger people, if you want to use a BPTV, you must be trained and you should know how to use this BPTV. Hamstring graft is a forgiving graft, but BPTV is not a forgiving graft. If you are starting with BPTV, this is a really challenging. If you are starting your arthroscopy, use your hamstring. Those patients who require BPTB sent to Arjun Lamichhane, sir.
Arjun sir, thank you, Amit sir.
Last question, Vivek.
Yes, sir. Okay, sir. So Amit sir has rightly pointed out there are multiple problems with BPTB graft, not only graft harvest, in graft management as well. Sir, are there any tips and tricks when you have graft tunnel mismatch during your BPTB use? This is the last question, sir. Arjun sir, you are muted.
Yeah, Vivek, this is one of the common problems. And for this, before making a tunnel, you can measure the total length of the graft. And then accordingly, you can plan making the depth of the femoral tunnel also to some extent, not always. Okay. And another, if there is about 4 to 5 millimeter of excess length of this graft plane, you can twist it out to 5-6 times so that that can decrease the length also. And another is if it is completely out of the hole on the tibial side, then what you can do, you trim the this bone part, and then you can fix with the soft tissue screw also. Another way, somebody do like to make a trough on the tibial side, then it fix with the help of then you fix with the a screw on the interference screw and make a tunnel and fix on the tibial side also the secondary fixation techniques.
Thank you, Arjun sir, for such nice presentation. And we have had very extensive discussion in BPTB. So any questions regarding BPTB can be posted in chat box, and I would like to request Arjun sir to answer them, and we'll discuss if there is time at the end of our session. So let's move on. And next topic, next graft to be discussed is quadriceps graft. And to discuss about quadriceps graft, I would like to request Dr. Bibhuti Mishra to share his screen and go on with presentation. Dr. Bibhuti, all yes.
Dr. Vivek. Namaste and very good morning to all the respective teachers, my teachers, seniors, and my dear friends. So I'm so glad that I got an opportunity to speak up here. So let's start with the quadriceps graft. So let me share my screen first. Hello everyone. So today I would be talking on the quadriceps graft harvest. So as we listened before also, this quadriceps graft, it came after the bone patellar tendon bone graft, and at certain time it was a very useful graft and people used to use it along. So there is a paper which came out in 2009 in Journal of Arthroscopy that compared the ACL reconstruction with this bone patellar tendon bone graft and the quadriceps graft with bone plug and without bone plug, and they found that they have the equivalent results, and no difference in results between men and women were also seen. And ACL reconstruction using the quadriceps tendon autograft was an effective surgical option that has reduced donor side morbidity. That is what they finally concluded. So quadriceps graft is one of the useful tendon graft which was invented by Marshall et al. In 1979. And since then, it has been a useful graft of choice for ACL reconstruction because it provides a greater range of versatility. It can be used for single bundle ACL reconstruction with or without bone block, for double bundle ACL reconstruction with bone block, for PCL reconstruction, for revision ACLs, for multi-ligament reconstruction, and for augmentation of isolated frontal tears. So a poll at American Academy of Orthopedic Surgeons in 2010, they showed that only 1% of orthopedic surgeons still use the quadriceps tendon as a graft overall. So despite all the versatility, why this graft is less preferred graft? Maybe because people are afraid of the long incision, anterior knee pain, or the extension lag that is seen in few of the cases. But then there are good things like we can preserve the hamstring anatomy and function if we do the quadriceps graft, and then if we take the central quads and free tendon autograft, then there is a low risk of patellar fracture and bone bleeding. There's less anterior knee pain, and the knee extension is also achieved sooner and better. So let's discuss a little bit about the quadriceps anatomy. So quadriceps has superficial layer, middle layer, and deep layer. The superficial layer comprises of rectus femoris. The middle layer has the vastus medialis and vastus lateralis, and the deep layer has the vastus intermedius. This vastus intermedius, they just sit below the rectus femoris. And if we see the sagittal section of the image of, of the knee, you can see that the width of the quadriceps tendon is more in comparison to the patellar tendon. So this also, we get an even thicker graft in comparison of the bone patellar tendon bone graft. So there are different techniques of quadriceps graft harvest. As we say, we can use it for double bundle, we can use it for single bundle, with bone plug, without bone plug. And recently, we are also coming up with a minimal invasive partial thickness graft harvesting technique that we used in the same manner as we use the semi-tendinous grafts. So I would be talking in very brief about all of these techniques. So first of all, let us see how the full thickness quadriceps graft can be harvested with bone plug. So this is a cadaveric dissection video taken from VUMEDI, which is a well-established good site. And so we can see you mark from the superior pole of the patella 1 centimeter above, you mark give incision of about 5 centimeters. And after giving, you dissect the soft tissue and expose the paratendons. So once they are all exposed, you try to measure the length that you want to get for the tendon. So generally 80 millimeter is marked. And then after that, we take the width, and so total breadth is measured, which differs in individual to a little bit. And after it is measured, we target the middle third of the graft. So how much is the middle third of the graft? And then after targeting the middle third of the graft, we dissect the paratendons, and then we give 2 parallel incisions. And we just give the medial one first, because we want to avoid the damage to the suprapatellar pouch if we go for the lateral one first. So we generally give the medial incision first, but it depends upon the expertise. Few people are very good and they can do whichever way they are confident about. And then after 10 millimeter quartz width is measured, we give the another parallel incision and we dissect it. So the graft is dissected till the superior pole of the patella. And then we again measure it, whether we have achieved the acquired length or not. And then we mark the bone plug. So what if we mark of 1 centimeter breadth and 2 centimeter length at the superior pole of the patella. And with the small oscillating saw, we generally cut it. But then we have to keep in mind that we should not go beyond 10 millimeter. We can do less than that and cut it further with our osteotome, but we should not go more than 10 millimeter. And after making the final cut with the osteotome, we release the graft. And then the next stage is the graft preparation with the 2 millimeter. And then you see we dissect the graft for the double bundle reconstruction. There is a fine line between the rectus femoris and the vastus intermedialis that I talked about, the soft tissue line. And through that soft tissue line, we can dissect the graft. And that makes a very good dissection. So we have now 2 bundles, the anteromedial and the posterolateral for double bundle ACL reconstruction. But for single bundle, we can use it as a one. So next we see is we want a full thickness quadriceps graft without a bone block. So if we want it without a bone block, this is another thing from the Blumedi. Surgeon is from Romania, and then he has shared it. So you have to give a 4 to 5 centimeter incision, just superior to the superior pole of the patella, and then it's a vertical incision, and then you expose the tendon. And after exposing the tendon, you give 2 parallel cuts in the same manner as we discussed before with the bone plug. But then the only difference in this case is that we extract the graft from the, we make the first horizontal cut at the superior border of the patella. So before doing that, we measure the breadth, and then we pass a right angle, taking the full thickness, and after it's above, we release the distal end of the graft first. So it's the middle third of the graft taken, full thickness is elevated, and the distal end is released. Once the distal end we are cut enough, we just bend it, and the distal end is released. After the distal end is released, we hold it at the right angle, and then we stitch. So this generally, this side of the graft, we target it for the femoral side during the ACL reconstruction. So after making the whip stitch, we give a traction, and then with the help of the knife and the scissors, we further dissect it. To acquire the length. So you can either increase the skin incision for your comfortability, or if you want to carry on with small. So you achieve the length, putting the 2 parallel incisions, same plane. And releasing all the adhesions nearby. So you see, he's doing a finger dissection to release all these adhesions nearby, and then he's trying to achieve the length of the graft. And then the graft is taken out. So this is a quadriceps, full thickness quadriceps graft without a bone plug, and the significant length of 8 to 9 centimeter long graft is there for preparation. So then there is another technique, which is the minimal invasive, which is superficial quadriceps graft harvesting, and this is our technique. So my teacher used to do it, and now even I'm doing it. So you hold leg is hanging in the 90-degree of flexion, and you just give only 2 centimeters of incision just above the superior pole of the patella, and then you just try dissect the paratendons, and then you mark 6 millimeters of the lateralized graft. Why we mark from the lateralized portion here is that we think that in lateral side there is more tendinous than the medial. Medial is more muscular. So, and then we dissect it, and then we just try to come out only taking the superficial layer. There is a plane I explained between the rectus femoris and the vastus intermedialis. So you will feel a giveaway sensation, and from that you can just turn in your right angle, and then it comes away. So you can see that in this case that we pulled above, it was thinner than in the previous case. So that is the only superficial layer. and then we hold it with the orthochord, and then we release the distal end just superior to the patella. And after it's nearly released, we just bend the artery forceps, and then you see we have released. Now next step is to put the whip stitch. We do it with orthochord. And after whip stitch is put, what we do is we try to elevate the distal end with a dissection 2 to 3 centimeters. So you can see there is the deep layer is intact there, and we are only dissecting the superficial layer. So the distal layer is intact there, and we are only dissecting the superficial layer.
Max.
And then we insert the same closed loop tendon stripper that we do for hamstring graft. Then we pull it gently, just insert it before, and then we extend the knee. And then we pull the thread, whip stitch, and then we just push the tendon stripper, the closed loop one. In the same way, we extract the hamstring graft. So we should be very gentle. There are few chances of graft cut, and then you see we got a beautiful quadriceps graft, very long and very strong one. And then we prepare it in the same way we prepared the hamstring graft. You can see the length of the graft. And then we close the paratendons over there with the V grill, number 2. You can see the incision size. This is just 2 centimeters. And and then we prepare it in the same way. As we do the hamstring graft, we put the rigid loop into a button and measure the size, quadruple the graft. You can either quadruple it, or you can either triple it according to the size you need. And so you can see the 10.5 millimeter thick graft is there. And this is the length, 10 centimeters, not bad, more than 10. And that is the size of the wound. So this is our recent technique that we are doing with a very small incision. So there are other papers published as well with this minimal invasive superficial graft harvest, but then they do it with an Arthrex quadriceps knife harvest, and that is very expensive. We cannot afford it. So we just go with a closed loop tendon stripper that we have, which is a Jagar technique. And so finally, I would like to conclude by saying that quadriceps is a versatile graft. There is less donor site morbidity and very strong graft as well. A good length quadriceps can be achieved by the minimal invasive technique as well. And after quadrupling, a reasonable diameter of 9 to 10 millimeters can be achieved, which becomes a strong graft for fixation. The whole process takes no more than 5 minutes for all the techniques that we have explained. So let's make the quadriceps a future graft. Thank you.
Thank you, Dr. Vibhuti. That was very nice and nice presentation. Dr. Vibhuti, there are some questions in chat box. Before that, I would like to ask you a question. Is there anything like Dr. Devi? Dr. Dhana, please. Okay. Is there something like the layers of quadriceps graft, like a superficial layer and superficial plus middle layer and whole thickness of the graft to be harvested according to the various procedures that is to be done in around the knee, like like MPFL or ACL or PCL or something like that?
There is nothing like that. Why I was telling all those layers is that when we present this, most of the time we get the questions like, how can you really dissect the superficial layer from the from the deep layer, or how can you pull it off? So what I meant is, when you see the anatomy, you see the vastus lateralis and medialis sitting at the two sides, and above is the rectus femoris, and the vastus intermedius, which is the deepest stuff, that just sits beyond, just below the rectus femoris. And so that is a very good plane. We also saw in the bone patellar tendon bone graft that we dissect in between that plane, and we get the two bundles like anterior medial bundle and posterior lateral bundle. So it's a similar way. When you put a right angle and then you try to dissect very gently, you feel a plane there, you feel a giveaway, and then you can insert your right angle through that. And that's the reason, because I explained all these because this was a very common question that we used to get whenever we presented this technique. And there is nothing like in this particular we can do this, or in that particular we can do this. And I have never used or seen my teacher use a full thickness quadriceps graft. We have always used this partial thickness, so I have no much more idea about the full thickness graft.
Okay. Thank you, Dr. Vibhuti. Dr. Naveen Tripathi, please come up with the question in the chat box.
There's one question from Naveen Karna sir. He says that, is there any experience of using ready-made knife available by various company? I think Vibhuti has mentioned about that. He said that he has no experience on that, but there are some available knives for by various companies.
Not many. There is Artrex has one. There are guys in Vellore CMC. They use it. We know that because they have also presented a similar paper. That is that knife is quite good, because there is a length over there. You pull it just to the acquired length. You want 9 centimeter, 10 centimeter, and wherever you are, you just pull it from back, and then it will cut from the same ligament. But that is a very expensive thing. We cannot afford it.
Since there are no more extra questions in...
No, can I ask one thing, Vivek?
Yes, sir.
Just for the sake of completeness. Vivek, very nice presentation, okay? I congratulate on that. Showing what you, in the videos, the first two technique with the bone plug and without the bone plug, the way it was done, I feel that is a full thickness graft.
Yes, sir.
And what you have shown could be a full thickness, could be a partial thickness. No matter, you have to, it's still an open question whether you want to do it. What I wanted to ask was that, are there any contraindications for taking out quadriceps graft in an ACL injured patient? Specific cases where you would not want to do a quads graft?
So, I mean, the problem with the quads graft that literature has so far said is the anterior knee pain, or you have a, lack of extension, or somebody even says that there is chances of quads hypertrophy, sir, in long run, if the patient is not doesn't show you compliance with the physio and things like that. So it's something like benefit outweighs risk. To me, what I take is, in multi-ligament injury, you cannot do everything with the hamstring. So you have to go for the second option. Either you go for the peroneus longus or you go for the quadriceps. Now it depends upon the surgeon to surgeon. If you are comfortable with the quadriceps, if you are comfortable with the peroneus longus. So in those cases, especially and the patient is not a sportsman, then you can go with the quadriceps. But then if a person is a sportsman or a footballer, then I would prefer a quadriceps. But if the patient is, I would not go for the peroneus if the person is a sports person. And if the person is not a sports person, then you can go with the quadriceps, because it has a very good rehabilitation, sir. Very early rehabilitation, and the patient comes back with a good feature, sir.
Okay, thank you, Vivek. I was talking about isolated ACL. If you are treating a multi-ligament, that's a different story. You're never going to get 100% knee in a multi-ligament or a dislocated knee. You can use anywhere, Have you, you've been using CQT, it's a quadricep tendon. Do you use that routinely?
No, sir.
You don't do that?
We just
okay, what I suggest is that if you do quadricep tendon in your primary ACL reconstruction, it would be a very good study, if you can document that post-operative, range of motion, what is the status of the quadricep muscle as a whole? Do you have any problem in achieving extension? Do you get, some problem? That would be a good study, because I feel, like I said, the method done by Professor Freddy Fu, and the one that was done by that Romanian is quite totally different, and yours is a totally different technique, you know. And as far as you ask me, you know, I do a lot of superficial quads in my MPFL reconstruction. You know, there is a clear demarcation of superficial, deep, and the middle layer, you know, and it's been very much highlighted by Dr. Deepak Goel, who started the superficial quad, that you can usually see that plane between the superficial and the middle layer just around 2 centimeters above the of the patella. And you might be, because you do that in a blind technique, you know, you might be taking out only the superficial part. Maybe in the proximal part you take a full length, and it's quite amazing, you know. I feel very impressed by the length. And like I said, in the one that Dr. Freddy Fu showed and the Romanian surgeon, they were using as a single strand, you know, but you could quadruple, even you triplicate it and you could quadruple the quad tendon. That gives you a better, you know, diameter. Okay, good. Thank you. Thank you, Bibhuti.
Okay, sir. Final words, sir.
Bibhuti, can I?
Yeah, yes, sir.
Bibhuti, since I have the opportunity, could I just clear a query? Like basically, we are used to doing the full thickness quads, right? So basically, what we're doing is we are doing similar to what Ishwardai was saying. We're doing a dissection from proximal to distal. So we're able to find out the exact amount of thickness that we usually get, right? Could you just repeat what you said regarding taking that thickness in your technique? From the lateral side, you put that right angle. And
I will say.
Rajesh sir and can I intervene, sir? Amit sir just called. He has some issue with the electricity, and his backup is not so long, I think. So I think we have to go for his presentation, and we'll continue this discussion later.
Okay, fine.
So I request Professor Amit sir to.
We can discuss later if we have time. Yeah.
Okay, am I audible now? Okay, is my slide visible and am I audible?
Yes, sir. Yes.
Okay. So, respected all, thank you very much. It is going to be a very great discussion. I just like to bring a relatively newer technique of peroneus longus harvest and my concept of peroneus longus harvest. So at the very outset, let me disclose by saying that peroneus longus is not my primary graft. And I like the concept of not violating environment of the knee. That makes me more liberal in using the peroneus longus graft. As my previous colleagues have already discussed about BPTB, unfortunately, we couldn't discuss hamstring, but quadriceps is very nicely elaborated by Bibhuti, and I'm going to talk on peroneus longus. If you divide all this graft into two groups, you can essentially divide it into two groups. One is around the knee, the other one is
hello.
Comic froze, I think.
He's frozen.
Let's give him a few minutes. I think he'll come back.
Yes.
नेटले त आज धोकै दिला जस्तो छ
फोन गर्नुभयो ओके इन्टरनेटको प्रब्लम भइरहेछ भन्दै हुनुहुन्थ्यो
So anyway, you know, like Bibhuti, you are in Viratnagar?
Yes, sir.
Okay. So how is the situation there?
The situation is not good, sir. The thing is that
I like your mustache. I like your mustache.
Thank you, sir.
Good. Yeah, I suggest that you know, whenever you use your CQT, your method, you know, you should have a good follow-up of your quadricep function, that there is a doubt. Even Rajiv was, I think, was pointing to the same thing, that it's the first two method you showed was a total. I think it was a full thickness, and
Yes,
your
sir.
is kind of a little bit blind, and so proximally it may be superficial, but up. I mean, distally it's superficial, but proximally it must go somewhere
Yeah.
into the depth. And I had a talk with Rajiv also, last time when we
Yes.
were in, I think it was in Dhaka or something, and he was asking me. I was also conscious of what he was doing, but I was quite impressed by the length of the graph you took out. That is very nice. And you have to point it out that when you take out I don't know, the security is coming up, central quadricep tendon, Sachin and everybody, those guys from India are talking about it, but I think they also do it like Freddy Fu and this Romanian surgeon, where they take out the full thickness and they don't have that much of length. Yours was so long that you could triplicate it and quadruple it, and that gave a very good. And I would always say, I would recommend that get a proper evaluation of quadricep, and publish that, and then that would be, you won't need that special knife made by the Arthrex or somebody, like you can do that with your own normal stripper, and that's a good thing. You should follow up on it. I think it's a good work. It's a good work.
Yeah, I also have experience in two cases, as I saw the presentation by Vibhuti in.
Thank you, sir.
Okay, and then I also found this fantastic graft with length of more than 40 centimeters, and I could also quadruple it. And it was not a primary graft, but is in case of multiple ligamentation.
So it's very good. I would say that this graft is very good for the revision purpose if you have a multi-ligament injury. And we did 15 cases last year with Rajiv sir in Kolkata. And out of the 15, more than 10 were the sportsmen, and more than half of them were from Bangladesh and few from the Bengal and other parts of India. So, and they are doing quite good. So we are waiting for the follow-ups, and then we are going to publish it. That's why only we are waiting right now.
Even I found that is less
Yes.
painful to
Yes.
the patient also, and the weakness of the quadriceps muscle is also not there as an issue.
Yes.
And then even the
Dr. Arjun, that we have to qualify. I think, like some people complain of soreness, even after a hamstring graft, they're always complaining of posterior medial soreness in the thigh. So if you are taking the full thickness of the quadricep tendon, or maybe a partial, I don't know, you have
no,
to.
I'm talking a superficial one.
Yeah, superficial is, yeah. Superficial.
I am back.
Yeah, back. Okay, Amit,
back.
okay, let's carry
No,
on.
we can continue because my electricity is resumed now. We can continue the discussion and then I'll come back with my presentation.
Okay. Rajiv had something to say. Rajiv wanted to ask something.
Sir, please unmute yourself.
Rajiv, unmute, please.
I'm sorry, I was on a call. Yeah, I was on a call. Okay, so what I was basically trying to say is, what was I trying to say? One second. So what I was basically trying to say is, when we are dissecting with disease,
now you're out.
Proximal to distal, right? So we get a very good idea of the plane. I think Vibhuti's technique is very nice. It's very nice. He showed this to us before also, I remember. Very nice technique. The thing is, we are coming from proximal to distal. So we are able to decide the thickness. So my query was, you're going to take the lateral side of the, how are you going to decide thickness? Could you repeat that? You said that. Could you repeat this for all of us?
The thing is, we don't start from the lateral side. We lateralize the graft. We lateralize the graft, sir.
Okay.
What that means is, if you take the central tendon, you measure the whole length of the quadriceps, and then you take the middle 1/3. Ideally, that is what.
Okay.
But then, if in this case, what we do is we have only 6 millimeters to take. In that, we target for the 10 millimeters of the breadth. But in this parcel, we only target 6 millimeter, because ultimately we are going to quadruple or triplet or make it double. So we achieve the breadth, the girth, sir, the girth of the graft. So what we do is we just take 6 centimeter, but then that 6 centimeter needs to be little lateralized than medialized. You can put it from center, but if you lateralize it a little, the tendinous component is more. But then, yeah. And since it's not a full thickness graft, so there is no chances that you are going to damage the suprapatellar pouch. That happens when you make incision over the lateral aspect. So that is one benefit over here. So you just
does that vary according to the height of the individual? Does that vary the length of the graft?
Yeah, it varies, sir. but not
Okay,
that
very-
significant.
So how
but
reliable is your graft actually? You must have done so many cases, right? How reliable is
15
your
cases,
graft?
sir. We have 15 cases, sir. We did 15 cases,
Uh-huh.
but I told you more than 10 were sports person. I mean, who had eventually very good height, and then
Okay.
few of the revision cases we did, there was 2-3 ladies, but then the size
Uh-huh.
of the graft was not less than 40, sir. It was very
Okay,
nice.
good.
The whole
So my
scale.
question is, my question to everybody, I think everybody can answer this. Why is the Kishore Dai can also answer this? Why is the quadriceps not so popular then?
Yeah, that's why.
Yeah, that's the question.
That's what.
Because see, with hamstrings, we're often landing up in trouble because we're getting very small graft, especially in our part of the world, right? We're getting very small graft. So why is the quadriceps not so popular? That's the question that I wanted to ask. That's
Yeah,
all.
because-
That's all I have to say.
Yes,
No,
sir.
no,
That's-
Rajiv.
Ajay.
Sorry, Vibhuti. The CQT, people are now saying central quadricep tendon. It's coming up, in the West. CQT is coming up. Can I just add one thing, why Vibhuti should be lateralizing? Why I also follow this concept, when you look up the whole anatomy of the quadricep, he rightly pointed out that the most superficial is the rectus femoris. Where does rectus femoris attach? It goes more laterally towards the iliac spine, the anterior inferior glenoid area. But the vastus medialis and vastus intermedius, all those muscles are more in the deeper and they come medially. They are just above the femur, and they are, if you look up the anatomy here, the superficial part, you can see just the superficial part of the quadricep tendon I'm talking about. The tendon is going up like that. But whereas the deeper part, the vastus medialis, intermedius, and the laterally is covering the femur, and it's coming from the femur. So when you direct your direction towards the lateral, we might be getting a longer part of that, the superficial part of the rectus femoris.
Yeah.
And
Let
even
me-
it is aponeurotic, I think, then the tendon is part in the proximal part.
Let me share. Yes, let me share a discussion that has happened, including Dr. Rajiv Brahman, that Vibhuti was saying. This is a very good technique, but we have to understand. Rajiv raised a very important question: why it is not that much popular? It's because of the homogeneity of the graft. It is not popular. If you understand how the tendons of all these quadriceps, the tendon length of all these quadriceps are different. The longest tendon is because of the rectus femoris. So if you take a full thickness graft, then you understand the deeper structure which has a shorter tendon, and the superficial, the rectus femoris, has the longest tendon. So probably Rajiv Brahman was also saying that if you do a cadaveric study and identify how this is coming up, then most likely it is not the quartz harvest that Vibhuti is doing. Most likely this is a rectus femoris tendon harvest he is doing. And I think this has to be verified. We have spoken to Rajiv also and identified this is a very good technique if you can harvest the rectus femoris, because this has relatively lesser function of extension than the other tendon. So probably doing a cadaveric study after harvesting and identifying what actually it does, rather than just harvesting and getting a very good graft, and what is its implication inside, it is explained. And then Vibhuti very nicely showed, and I suggest Vibhuti, with our experience of 4 papers in arthroscopy technique, rather than publishing the outcome itself, it will be interesting to publish the technique first, then you patronize the technique that you have invented or you have developed this technique in arthroscopy technique. If you are a Nepali, there is no problem in monetary also, and then you go on publish the outcome of that technique, probably that way. And then I will definitely suggest, if you can manage, go to BPKI, just do harvest this and do a dissection on the cadaver. You take good pictures, so identify that how it goes, what it takes, what it does to vastus medialis, what it does to vastus lateralis. Is it coming from rectus femoris also only? If it is coming from rectus femoris only, then it is not the quadriceps harvest. Probably this is the rectus femoris harvest, and completely a different idea. But the graft you harvest is fantastic. This is long enough, this is thick enough, provided it doesn't have any morbidities later on.
That's a good idea, sir, because looking in the cadaver once again and then analyzing the things would be a great idea. I will try to cooperate because my wife is anatomist at BPKHS, so I can manage.
That means that is your bonanza.
Bonanza.
Yeah.
Bonus for you. You tell your wife, get a limb and dissect from the hip to the knee and identify rectus femoris.
Make sure that you hire a cameraman for that day. Pay him handsomely. You hire a cameraman, because harvesting this thing is not. I remember that from one friend from Mumbai has offered us 10s and 20s of cadavers to do all our techniques and then identify their biomechanical effects. But unfortunately, because of this, you have to do that because you have to have a scientific basis on it.
Okay, Dr. Vibhuti,
And then that
there is
graph
one.
is fantastic.
Yes, sir. Thank you, sir. There is one question in chat box. This from Dr. Sunil Singh Thapa. Is there any concern of quadriceps weakness, and do you do any modification in early postoperative rehab protocol while you do this minimal invasive graft harvest? And along with that, he has another question. Is there any increased risk of arthroplasty with quadriceps harvest? I think this has been mentioned in literature. So, Dr. Vibhuti, all to you.
There is less chances of arthroplasty since we still advocate of the superficial layer only. We have to still prove it whether we have only superficial layer or we have the deep layer. And and I don't think in our cases we saw any sort of extension lag. The physiotherapy was same protocol that we put the post hamstring. There is nothing else. Same the quads strengthening, first the hyperflexion of the hyperextension of the knee, followed by the flexion and cycling. But the thing is, my sir is very aggressive in terms of physio. He would first put the patient on the same day on the bicycle. So in the physio, but then after I joined, I said, sir, please leave for one day because patient is in spinal and then patient keeps on irritating me. So from the next day, he goes for a very fast rehabilitation. So and at the whole results, as Amit sir said and Ravi sir said, sir said, that the whole results are yet to come. So we are still learning. We have done 15 cases, and then we are sitting back and looking how the results are coming in 1 year follow-up. Then only we can confidently say something.
Okay, Dr. Vibhuti, very nice technique. You have said that last year you have done more than 15 cases. Were there any cases of premature amputation? And next question is, what was the average time to have full extension in those cases who had the quadriceps harvest?
There was one case of premature amputation done by me because I was a learner there in the beginning. So, but then he could again control it because we take a very small 6 millimeter depth. So we can little bit of again medialize it and we can take the graft. So that doesn't make any difference. That doesn't make so much of problem in this case. And what was the next question?
Next question is, what was average time to gain full extension in quadriceps harvest group? Your technique.
Full extension.
Yes. Because the problem with quadriceps harvest is we get delayed.
Actually, we followed the same protocol and then we didn't document all those things, that full extension. I mean, we have a separate physio unit that is doing all the documentation. I haven't been through all those data. When I write the paper, I will get all of them and then I will start writing. Everything is so well organized there. But then I cannot tell you in this much of time. But then when the patients came in follow-up to us, when I saw the patients in 6 weeks, probably, most of the patients were from Bangladesh. So when I saw the patients in 6 weeks, so what I saw is they had a very good amount of extension is there. There is no extension lag. I couldn't find extension lag at 6 weeks. That is the only thing I could tell you right now.
Okay. Thank you, Dr. Vibhuti. That was very nice technique. I think there are no more questions in the chat box and no more questions from our seniors. So let's go on to
Vibhuti's mustache is very good. You should continue with this mustache.
I have been changing my looks this year, sir. Every month are different. So let's see.
Okay, let's go ahead. We have only 30 minutes left. Go ahead.
So I would like to request Amit sir to share his screen for peroneus longus.
Okay, am I audible and visible?
Yes, sir. Yes.
So thank you very much. Sorry, I had to rush because but there was no electricity. But fortunately, the electricity is back and I can present. So today I'm going to talk on peroneus longus and how to harvest that and what are the pros and cons of peroneus longus. Okay, so at the very outset, again, I would like to disclose by saying that peroneus longus is not my primary graft. But I like the concept of not violating environment of the knee. That is why I'm more liberal in using this. I'll talk about what do I mean by violation of the environment of the knee. My colleagues have already discussed about that. Unfortunately, we were not able to listen to the hamstring. And I'm going to talk about the peroneus longus. If you divide all those 4 grafts, they can be divided into two groups. The BPTB, hams, and quads, they fall into the graft which is taken from around the knee. So if you take something from around the knee, there is a possibility that it will change the integrate kinematics or finite kinematics of the knee joint. So whereas if you talk about peroneus longus, it is away from the knee joint, and we know that this is not going to hamper the movement or any finite movement of the knee joint. But we know that it has some effect on ankle and foot. We'll come to that later on. I would like to introduce to all of you this 4-bar linkage system. This is basically used by the arthroplasty surgeon. My colleagues who do arthroplasty, they will understand what is this 4-bar linkage system. For my arthroscopic colleague, let me elaborate a little bit on this 4-bar linkage system. This is developed by the Arnowski and the Bryan, who say that your ACL is parallel to the quadriceps and your PCL is parallel to the patellar tendon. So if you harvest any of these structure, if there is a damage to any of these structure, then the parallelogram will be disrupted, and any disruption in this linkage system will cause sagittal plane instability. We know that if there is a patellar tendon rupture, there will be excessive translation of the tibia into the anterior part. That grossly says that probably these all structure has something to do with the sagittal plane instability. This is more of a biomechanical study which says that there is an integrate change in the movement and the tension of all these 4 structures when they are pushed through certain range of motion. So each structures are important, and their adequate tension to maintain other tensions are important. And this is from a biomechanical study which has proven that all these structures' strength are very, very important. So I told that in axial, these all 4 linkage system is important. This video I have taken from Robert Smijelski talk, which shows that the role of hamstring in maintaining the rotation of the knee joint. So hamstring is also important for the maintenance of the rotation of the knee joint. So if your hamstring is not there, probably the lateral structure will be more active and the rotation will be again disturbed. And the third point I'd like to highlight, this is a paper from 2018 which says that if you do a gracilis and semity harvest, there is an increased valgus motion of the knee joint. So to summarize this, all this effect of all this structure. So if you harvest BPTB and the quads, there is a possibility of sagittal plane movement disbalance. If you harvest hamstring, then coronal plane or rotational plane disbalance is a possibility. And I don't know, this has not been very well established, but could this be the reason why even after anatomic ACL reconstruction, the incidence of osteoarthritis is still very, very high, even when we say a total anatomic reconstruction of the ACL. When coming to the peroneus longus, is a very good graft. It is easy to harvest. The strength of peroneus longus is absolutely fantastic. The graft size this is one of the best graft you can have, and the biggest size you can achieve. Even by the doubling it, you'll get about 10 millimeter, 9 to 10 millimeter. The complications are probably comparable to other soft tissue graft. And as far as the donor side morbidity, probably this is the aspect in which many people talk about the donor side morbidity, and that is one of the restriction for use of the peroneus longus. Let me bring to your notice some of the very recent paper, which is from recent paper. This is the oldest one I could find out. of the use of peroneus longus tendon, and it was started in 2008 actually. And they say that peroneus longus tendon can be appropriate autograft source for ACL reconstruction, avoiding potential complication of autograft obtained from the knee region. So all those concepts that I was trying to say, that any graft harvested from around the knee region will have certain change in kinematics. So if you take a graft from away from knee, probably will sort out that problem. This is a hypothetical thought, which is also been mentioned in 2008. This is 2015 paper in Bancha's paper, who actually taught us when in 2014 we were in Hong Kong, myself and Ishwar sir, we saw this peroneus longus harvest. And when he was here for first BNBD course, Pansa taught us how to do. And this is his paper, though published in Journal of Medical Association of Thai. He said that it has several morbidities, but can be an reserve option for ACL reconstruction as well. And they have not outright discarded. But if you see the recent studies in 2018 and 19, they say that peroneus longus is superior to hamstrings in case of ACL reconstruction because of various advantages. And as far as the morbidity is concerned, this is a study which studied the morbidity in terms of eversion and the first ray plantar flexion, which is the main peroneus longus function O. And they say that ankle eversion and first ray plantar flexion strength at the donor side were similar to those at the contralateral healthy side, with no donor side morbidity. And this suggested that the peroneus longus tendon is a promising graft in ACL reconstruction. Even so, people are talking about using peroneus as a first choice for their ACL reconstruction. This is another one in which PCL reconstruction, for which we use peroneus longus very commonly. They say that PCL reconstruction with peroneus longus graft in 2 years follow-up, they say that it has good outcome for PCL, and foot and ankle scores are also very good even after the harvesting the peroneus longus. This is another paper of 2020, the most recent one, which says that satisfactory functional and MRI outcome at the foot and ankle following harvesting of full thickness peroneus longus graft. And this also says that there is no residual morbidities of harvesting peroneus longus graft at this moment. So how to harvest the peroneus longus? There are basically two techniques of harvesting peroneus longus. One is the anterior half of peroneus tendon, peroneus longus harvest, that is also known as a partial harvest, which is usually done for the reconstruction of the ligaments around the ankle. Once I have used it when the graft size was not adequate, so I wanted addition of the graft, so I use a partial peroneus longus tendon. But what we are talking about, the total peroneus longus tendon harvest. So this is a video I'd like to demonstrate. This is our own video of peroneus longus harvest. The first thing is the marking of the fibula is very, very important, because it will give us where are all the slips of all these extensor or the peroneus retinaculum is there. So which is about 1 centimeter above the tip retinaculum. So you do not violate the retinaculum and give your incision just above the retinaculum. So this is about 1 centimeter, 1.5 centimeter retinaculum. So as you cut the skin and the subcutaneous tissue, you will feel the peroneus sheath. So here you can see that is the peroneus sheath, and underneath that peroneus sheath, that is your hamstring. So you have to be, sorry, not hamstring, peroneus. So give a nick into the sheath. So you can see that a nick was given into the sheath, and then extend this nick of the sheath proximally and little bit of distally. You have to be careful not to go very distally so that you don't violate the retinaculum. Then it is important to identify which one is the longest, which one is the brevis. The superior and the anterior one is the longest, the deeper and the posterior one is the brevis. So the one that is facing towards is the longest one. You can see that we have already tagged it with the suture. And if you see, this is superior. If you see deeper structure, that is the peroneus brevis. The other way is to identify it has muscle right there. So I'd like to try to show you the muscle. You can see that in the tendon there is a muscle, whereas in the peroneus longus there is no muscle. So the next thing is to do a dorsiflexion and the eversion and the plantar flexion of the toe, so that maximum amount of the tendon is delivered through the incision. So this is, it has been tagged with the silk, and then you do a dorsiflexion, eversion, and the plantar flexion of the toe, so that the longest amount of the peroneus longus is delivered, and then you cut it from its distal part. So here I am preparing to cut. You have to be careful so that you do not cut the skin or you do not cut some other structure, because a very close space, you have to protect your skin, and then you can gradually cut the peroneus longus. So here the peroneus longus has been cut. The next important step is to do a bulleting of the end. So as you know that the peroneus longus is very thick, 6 mm, and when you put a ethibond suture over it, it becomes bigger one and may not pass through the stripper of 6.5 mm. So that is why it is important to make a bulleting of that peroneus longus. So once the bulleting is done, I use a scissor to do bulleting. Then you apply a whip stitch in the same standard manner. So this is whip stitch is being applied. And once the whip stitch is being applied, then you have to see the whole length of the knee. So once it is passed, my assistant will put their finger into the head of the fibula. And once you pass your stripper, it should not go towards the posterior side. It has to go towards the anterior side, so that you preserve certain nerve there, the sural nerve, the superficial nerve, sural nerve has to be. So you go anteriorly. You can see that I'm going towards anterior and going right up to the fibular head. So once you go up to the fibular head, you can harvest the graft very easy, and you can see that the robustness and the thickness of the graft. Once it is harvested, then the second preparation comes, the preparation of the graft. As you know that the other part is stripped from the muscle, it may be very much ragged. So in the other side preparation, I do not apply a whip stitch, but I apply a finger trap stitch, so that it will bring all the small fiber and tubularize the graft. So you can see that the finger trap suture has been applied to this. And then your graft is ready for use for your whatever ligament structure, either ACL or PCL you want to do. I personally use for PCL. So to conclude my presentation, there are several advantages of the peroneus longus graft. It has been discarded by many by saying that it is a new kid on the block, but and then it yet to have good scientific backup. Although I have tried to review certain very latest literature, which gives us a good backup for to be liberal for the harvest of the peroneus longus. Foot and ankle morbidity still remains a concern, because many people cannot accept the fact that the most important peroneus, the peroneus longus, is being harvested. So however, at the end, I would like to say that peroneus longus harvest is a technique probably all the ligament surgeon should have under their sleeve, because we are doing a lot of multi-ligament injuries nowadays. We are doing a lot of PCL, especially in the female. So this technique has to be learned. Thank you very much. Stay safe and stay at home. The corona is rampant out here in Kathmandu. Thank you very much.
Thank you, Amit sir. That was wonderful presentation. So I think there are some questions in chat box. Dr. Naveen, can you please come in with the question? Naveen Tripathi.
Thank you, Vivek. So there is a question from Dr. Jagdish. He asks, can peroneus longus tendon graft be used in case of basketball player where ankle function is very important? Amit sir.
This is a very interesting and probably a good question. To tell you very frankly, for a basketball player, peroneus longus will not be my first choice of the graft. If it is a real basketball player, I would choose a BPTV for him rather than the peroneus longus. So at the very outset, we have to understand that at this moment, peroneus longus is not the primary graft. Having said that, if there are no other graft, if it is a revision case, and the other graft has been already used, probably I'll definitely will not stay away from harvesting a Peroneus longus. But Peroneus longus for basketball player as a primary graft is a big no. Does that answer, Jagdish, your question? I think.
So there is another question from Sudeep sir. He asks, is there any advantage of suturing Peroneus longus to Peroneus brevis?
Earlier, when historically at the start of Peroneus longus graft harvest, many people used to tie the distal portion or the distal stump of the Peroneus longus with the Peroneus brevis. But the studies, the Banchas study, they have shown that if you suture it, then it will form a bump and it's stuck into the Peroneus retinaculum. So it will give rise to more pain than any advantages. So probably nowadays nobody sutures. There are some old-fashioned people who still suture, but current recommendation is not to suture into the Peroneus brevis. It will give more pain than any advantageous function of the toe flexion.
So another question from Dr. Sushil. He asks, is there any specific reason for you using Peroneus longus graft for PCL reconstruction?
Yeah, of course. So there is a very special reason, because PCL reconstruction, usually a multi-ligament reconstruction, it comes as a multi-ligament reconstruction, and we all know that PCL is a bigger structure than the ACL. And as Vivek was also, Rajiv was also trying to say that most of the time for PCL reconstruction, our hamstring is really small. Either it has to be quadrupled, and if you do a quadruple of the hamstring, the length may not suffice, so that is why PCL, for PCL, Peroneus longus is my first choice in case of multi-ligament. Again, if it is a single ligament PCL reconstruction and his medial structures are intact, then I'll definitely take a quadruple hamstring for the PCL as well.
Okay, Amit sir, there is another question from Sushil Thapa from Bharatpur. His question is, there is another technique for harvest of Peroneus longus where they make one more incision below the retinaculum, and so that the length of tendon can be increased. What is your take on this, and any experience about this technique, sir?
Yeah, people come up with very, very good ideas. And if you want a long graft, and if you want the same Peroneus longus for PCL as well as for ACL, then you have to get a bigger length of this graft. So if you want to use the initial part of the Peroneus longus as a ACL and the superior part as a PCL, then you can harvest a longer part by giving an incision into the lateral aspect of the sole and detaching it right from its attachment. You can do that, but the purpose is completely different. I have not done that very often. I have not done even one, but I have seen people doing it. But in that case, the reason of harvesting the longer Peroneus longus is you can use the same Peroneus longus, some part single for the ACL and the remaining part double for the PCL. I think, okay. Does that answer your question, Sushil? But you can harvest, you are right, you can harvest a longer Peroneus longus. But if you want to use it for PCL alone, harvesting from the lateral side of the ankle is enough. The length is enough. You don't need a bigger size of Peroneus longus.
Okay, there are no more questions in chat box. Our seniors.
Amit,
yes,
Amit, I want to. Amit, you talked about a study where they have found there is no loss of plantar flexion of first ray as well as eversion. Similarly, one of the study done by Bancha, where he said up to 2 years he had noticed there is a weakness in the eversion and the problem in flexion of the first rays. In your experience, because you have also done so many cases, what problem you encountered after harvesting of Peroneus longus? And another thing is, have you ever seen somewhere, I had seen some people presenting about the CPN palsy after this Peroneus longus harvest. So in your experience, what problems you encountered?
So you see, both eversion and the plantar flexion will be weaker for about 8 months time. Then it starts gradually regaining. we should not forget that the peroneus longus has also a arch formation function. So what happens to the arch? Not many people have studied that. But as far as the toe plantar flexion and the eversion of the foot, many studies, even the Bancha's paper in 2015, then he again do a biomechanical studies in 2017 and say that probably after 1 year it starts recovering. And the MRI study also supports that this also regenerates, like hamstring regeneration, peroneus longus also regenerates, and they probably gain certain good amount of eversion and the toe flexion. But I'm not able to explain about the loss of arch of these people. Number two is your question about the complications. There are two basic complications of nerve injury, that is a sural nerve injury and a deep peroneal nerve injury. So to avoid the sural nerve injury, which is outside the sheath of the peroneus longus and the peroneus brevis. So if you notice how in the technique I showed, people suggest that you be inside the sheath. So you give an incision into the sheath and be inside the sheath. You do not widely open the sheath so that you do not go outside the sheath to damage a sural nerve. That is for sural nerve. For the deep peroneal, as you know, the deep peroneal comes back of the neck of the femur. So two things you have to be very careful is you do not go towards the posterior side. You be always towards the anterior side, and then when you push it, you have good pull into the graft so that you do not go all the way up to the neck of the fibula. So once it is stripped off the muscle, it will just come out. So you do not need to go right up to that. If you improve these two techniques, it will not have keeping my finger crossed. We never had these both superficial and the peroneal nerve injury till now.
Any more comments from our seniors? Ishwar sir, Arjun sir, Rajiv sir, Chandra
Dr.
sir.
Chandra is raising his finger. Yes, sir.
You always your choice is always you take a graft, peroneus longus graft from the injured limb or the normal limb. And does it
From
matter?
the same side.
Same side always.
Yes, from the same side.
So, is it wise to take from the normal limb because you have already injured the limbs? You know, does it matter?
You see, Chandra, there are a lot of research on harvest of graft around the knee from the other side, rather than violating the same knee by taking a BPTB, hamstring, or quads. Will it be better to harvest from the other side? There are few studies, but since peroneus longus is away from the knee and it doesn't have actually any function at the knee joint, so probably harvesting from other side is not very much talked about for the peroneus longus, but for the other structure it has been talked about. And my practical problem, I think my colleagues will agree, that if you ask a patient saying that you want to harvest from the other side and putting into this knee, many people will not agree to that. That is one practical problem I have. So in my practice, even in the multi-ligament knee injury, I try to manage from the same side, everything from the same side, all the grafts from the same side.
This is my question is to all the senior faculties. We have all discussed about the multiple graft options and their strengths. So are there anything like the choice of graft lead to failure? The choice of graft leads to some failure, like some graft is more good in terms of failure, long-term failure, and some graft has more complications like that. Is there anything like that?
Vivek, let me answer this, because recently I've been involved with a lot of studies on the graft. So whatever graft you put, it has to undergo ligamentization. So whatever strength of the graft you put, it will decrease by 80%. So now you see your table that you have shown initially. What is the strength of the BPTB, strength of the quadruple hamstring, and the peroneus and everything. So the strength is going to decrease. Probably our current concept in how to protect them during this ligamentization process I don't think that the strength of the graft available, all the grafts are stronger than the native ACL when you do an in vivo study or the lab studies. Probably strength of the graft has nothing to. How easily can be ligamentized is an important point that we have to understand. And in that context, BPTB, hamstring, peroneus, these all are dead graft. You put a dead material out there. So that is the reason why the preservation, the remnant preservation, which will give a direct blood supply to this graft, is very, very important. And this concept is coming.
The reason behind
that is my opinion. Other people, yes.
The reason behind this question is lately I have gone through one of the literature. I think this was the systemic analysis, and it showed the rate of revision in those cases where quadriceps were used. The revision rate was very high in compared to BPTB. So that was my only concern. Otherwise, there are many papers where BPTB had very good result, as good result as the quadriceps. Quadriceps has as good result as BPTB. That was my only. Any what is any take on this matter from our other seniors, Ishwar sir, Chandra sir?
I think Vivek,
yes, sir. Arjun sir.
Failure and success of reconstruction of ligament is not only on the graft only, is Dr. Amit already said. There are other issues also. How correctly you have reconstructed it in terms of, like, we all know tunneling and the fixation techniques and the rehabilitation also, so that every graft is going to be like necrosed, and that need to be regenerated. Ligamentization is to be done, and till that time that should be survived, that should be protected. And other things are how correctly you have done. And that situation is like in different studies they have done, provided that the technique is correctly done. And among them, they have studied and found that this because of this fixation, that there is some chance of in revision of hamstring construction.
Okay.
In my opinion, this is not only the graft, but how technically correct you do all the steps of reconstructions.
Okay. Okay.
Absolutely.
Thank you, sir.
The newer concept coming up is putting a collagen. You put certain different type of collagen into that part. We know that the tendon and the ligament have different structures. Different structure. We are trying to use tendons as a ligaments. So these are different structures. So whole purpose is to put a collagen, and then many people have not done a re-arthroscopy after ACL reconstruction, and then this changes a lot. So probably the biological part has to be understood. Biology has a very big say to it. If you put a vascular, we all know that as an orthopedic surgeon, vascularized graft will do better than a avascularized graft. There is no need of any proof for that. So that is the reason why we have to identify a better and the more possibility of the vascularization. That is why if you take a BPTB, which is a multi-strands, and then it doesn't have a coverage, you have covering, you have removed the paratenon, and then BPTB has a multiple strands of it. So it gives a lot of space for other materials to go inside, and revascularization and the collagen deposition is more in the BPTB. So BPTB will again emerge in some point of time, provided we have adequate address to managing the length of the graft.
So thank you, Amit sir and Arjun sir. As in trauma, we say it is the implant rarely fails. It is the surgeon who fails. I think it is same with us. Graft rarely fails. If it is us, how we do and how we rehab them. This is the reason why they fail a lot. So Nagmani, do you have any question? I think you have some question.
Well, more than questions, it's more kind of like we've discussed the graft choices. And since we have younger colleagues who are willing to start with this, so when looking from an outsider perspective, if I look at it, we have options, but we exactly don't know where to select which one. Suppose if an isolated ACL comes, if our expert panel could give some light in a concise way, all of them, like what they choose for multi-ligaments, what they choose for primary ACL, if you don't have, what do you choose for revision ACLs and all. If all our expert panels could say and agree to the grafts they use for primary, revision, multi-ligaments, or in two ligaments, because we have given the options, but the person who will start will not know what to choose first.
Okay.
So we start with Amit, sir.
Okay.
You see, for the younger colleagues, I'll divide whole graft into soft tissue graft and the graft with bone. CQT with bone, BBTB with bone, and the other peroneus, hamstring, even the other soft tissue graft. So managing soft tissue graft is very, very easy. So if you are not very confident of managing the bone graft, if you are learning, if you are a starter, probably rather than having a graft with bone, it's always good to have a soft tissue graft, because the management of soft tissue graft is very, very easy. Number two, how to choose a graft will depend upon two things. Number one is what is available to you. If you are a multi-ligament, doing a multi-ligament in which you need all 3 or 4 ligaments, then you don't have much choice to choose. The choice comes when you are using a isolated, the solitary graft. When you are using a reconstruction of solitary, then comes all which is the best ideal graft for this patient, which depends upon the patient demand, his activity. And there was a Bibhuti, I'm sorry, Bibhuti was asking, would you be comfortable of using a peroneus longus in footballer? As a primary graft, I will not use peroneus longus at this moment. I don't have enough evidence to say that peroneus longus will be my first choice for the footballer. Probably if given an opportunity, I'll try to use a BPTB. If not, then hamstring. So you don't be confused with what graft you are going to choose. The first two graft is the BPTB and the hamstring. So you base upon maximum time, 90% of the cases you will manage with the BPTB and the hamstring. In various practice, in my practice, 95% of all the ACL reconstruction is the hamstring reconstruction. Only 5%, especially very much elite footballer, they want to go back to their only these people will get that. So that much I can say. Plus your comfort of harvesting the graft. You should not struggle too much in harvesting the graft by spending so much time on harvesting the graft and then rushing on doing the ACL reconstruction. That is my basic. I'll be happy to listen from others as well.
Okay, Rajiv sir, your take on this matter. Sir, please unmute, sir. You are muted.
Yeah, Vivek, what was what choice of graft?
Yes.
What choice of graft?
What will be your choice of graft in isolated ACL or?
Yeah, it definitely depends on the patient makeup, right? It definitely depends on the patient makeup. But all the graft choices must be explained to the patient. In certain scenarios, you may have to help the patient to decide his graft, right? But I think everybody should be well versed with a hamstring graft, okay, number one, and a bone patellar tendon bone graft. Now, I would recommend that when you do a bone patellar tendon bone graft, that you must have the necessary equipment. Okay, so initially, if you're going to start off bone patellar tendon bone graft with an osteotome and a chisel, you might land up with problems. Okay, so I think you should invest in a proper saw, at least when you initially do your bone grafts, because there is an incidence of patellar fracture. Not that we haven't had it. We have had hairline fractures of the patella. When you do a lot of cases in certain situations, you may land up in problem. So when you know that's going to happen, you must be very careful. The hamstring, I think, is an easier, there is a less learning curve. I think it's easier to do it. Definitely there are complications there also where you can have amputation and things like that. Now, I liked Amit's talk on peroneus graft. It is a very easy graft to harvest. Okay, what I would like to add a little bit, I like that part where he talked about that bullet. You make a bullet and then put in your tendon stripper, because often that peroneus tendon is very big. Okay, and initially when we harvested it, we used even an open tendon stripper because we found the width of the open tendon stripper was bigger. So we would make that whip stitch below and hold that whip stitch and pass in an open tendon stripper and go. And Definitely. I think the harvesting of the peroneal tendon is quite safe because basically you are in that sheath and you don't do, when we are harvesting the peroneal tendon, we don't tend to do that to and fro movement when we push in for a hamstring graft. We just go in with the palm and just slide it in. So I think if you do it that way, I think it's a very safe tendon. Now, because, the literature also Amit showed, I mean, the literature that we usually look at, there's this author called Ratomi. Ratomi is the author for most of the publications.
Yeah, he's the pioneer of peroneal.
Yeah, he's the most. So we need more literature. We need more literature for that. But I think, Amit, it's a very safe graft. Like someone was saying, I don't use it as my primary graft. I use it for multiligamentous. I have used it from both sides. Okay, and patient has never complained of any weakness. And we must understand that the multiligamentous patient will not accept. I mean, you won't have a the patient is not going to expect so much of function, right, after a multiligamentous, like he's going to expect after a primary ACL. Okay, so I think it is a totally,
could you sorry to interrupt you, sir. Could you concise it for our younger participants?
Yeah.
What would be your primary graft in terms of individualized patients?
So I think for a primary graft for the younger people who are just beginning arthroscopy, I think it's essential to know the hamstrings and it's essential to know the bone patellar tendon bone. Okay, because bone patellar tendon bone is also a very important graft, especially for these active sports players. So if you know these two grafts, I think you can go on. Okay, the third graft is the quadriceps graft.
So which one first, sir? Which one first, sir? BPTV or hamstring, sir? Individual on the patient, sir. Sports and non-sports.
First, if you go for sports, you probably need to counsel for bone patellar tendon bone. Okay, if you go for a sportsman. Okay, but if you go for a common person, then I think hamstrings, because morbidity is less. Hamstrings that way. The problem with bone patellar tendon bone is there's a lot of morbidity associated with the graft. If there are complications, there's a morbidity associated with the graft. Okay, so that's all I have to say.
Thank you, Rajesh. Thank you, Nagmani. I think we have had some consensus. Bone patellar tendon bone graft and hamstring tendons are the oldest and time-tested grafts. So we have to begin with that. And for the beginners, as Amit sir and Rajesh sir has mentioned, the soft tissue graft are always the beginning graft because bone harvest is always difficult and need sophisticated instruments. So I think we have to start with
Vivek, I have two more questions for the expert panelists.
Okay, Nagmani, I just differ from Rajiv in the sense that for the beginners, if they want to do a multi-ligament, probably rather than a hamstring and the BPTB, I'll suggest them to take hamstring for ACL and the peroneus longus for the PCL, because we have done about 40 odd BPTB, and to tell you very frankly, every time you take a BPTB, there is some problem of mismatch of the graft tunnel mismatch, and then the chances because of the availability of the implants, then the counseling of the patient, you'll get a metal implant. It causes so many problems. So for the very much beginner, if they are doing a multi-ligament injury, probably hamstring and the peroneus longus will be the first choice.
Amit, I was not talking in reference to a multi-ligamentous for a beginner, right? So for a beginner, I agree with you. I would even like the beginner to consider a hamstring from the opposite side. Okay, that would, I think, be a safer option also than taking a bone patellar tendon bone.
Absolutely.
Yeah, I think that would be good. Yeah, I think I agree.
Sir, two more questions which we haven't taught, sir. We haven't discussed.
Yeah, go ahead.
One is we see several Western literature talking about, and some of the Indian literature is also discussing about it. To our experts are something which we never discuss in our meetings, but is there a future perspective of it? And second thing, sir, based on your graft choice, what would be your rehabilitation protocol, and what would be your counseling parts, important counseling parts to the patients, sir? Those two questions.
Dr. Nagmani, you are not clear in both of your questions. I think
yes,
he is clear to us. He is clear. I could Vivek, I could listen to his question. He was asking about the allograft. What is its future perspective in our country? The second one was he's asking. Okay, Yeah, he was asking allograft. And second one is rehabilitation changes after the various types of graft. That was his two question. For as far as the allograft is concerned, you have to counsel your patient about the allograft. For the sports person, I'll not use the allograft. For the low key people, allograft is a good choice because it doesn't have a donor site morbidity. That is one of the major advantage of allograft is doesn't have a donor site morbidity. So if you feel that some patient will have a donor site morbidity, in that case, allograft is good. For multi-ligament, allograft is good. Americans, they use allograft for even primary cases, but Europeans, they suggest that for primary cases, allograft is not good. As far as the rehab protocol is concerned, the basic rehab protocol is same for me. Either I use a soft tissue graft or a bone graft. But if I use a bone graft, my initial rehabilitation will be little cautious to achieve full extension of the knee joint, because there are papers which say that if you use a BPTB, the possibility of extension lag is very, very high. So you have to be very cautious about achieving the full extension. Yes, or Ishwar sir, Arjun Daik off.
Arjun sir is gone, sir.
I'm going to wrap it.
Yeah, yes, sir. Last question from Dr. Vibhuti. He was raising his hand, and then we'll wrap it.
Dr. Vivek, Dr. Sudeep is also there. Our Sudeep sir. He's joined late, so you can ask him
can
also
Sudeep,
and
yeah,
include
can
him
Dr.
instead
Sudeep,
of Arjun sir.
Okay, sir. Dr. Vibhuti, your question, please.
No, it was not a question. I was trying to say that since I am also a beginner and young colleagues like you are, so whenever you do something, you never do without a learning. You see somebody you work with, or you do a workshop, or you do something somewhere, and then only you do it. So what my professor used to tell me in my MS program is that you always do the procedure that you are best at executing yourself and doing the best. So it doesn't matter for me if I would have been a beginner. For me, it's whether during my learning I have learned better way of doing with peroneus or hamstring or quadriceps. That should be done first for me. That is what I consider. I'm confident at, because I'm a beginner and I have to execute the good results. So I should be first going with whatever I have learned properly. And once I'm confident, then the next step is that I would be thinking that now which one gives the better result. Then I would think that for PCL, we can go for peroneus, for ACL, you can go for hamstring. And those are the things that in second stage, we start thinking. This was an overall thing. This was not for, you always be what you are confident at as a beginner, what you learned, what you see your teachers, what you assisted, that is the first thing you should be executing. And then you should be moving forward. So this is something, because I first saw the hamstring during my residency. Ishwar sir is here. He was my teacher, and Dr. Baskota. So we used to hold the legs and see the things there. And then that was the first thing I saw. So when I started doing myself in 2015 at Novel, so I started the first one in hamstring. So, but then later on, I went for further fellowships, and today I'm doing quadriceps, peroneus, everything. But then that was the beginning.
Okay, thank you, Dr. Vibhuti. Okay. Amit sir, you wanted to tell something? You raised your hand.
Vibhuti is right in some sense, but I do not agree. Though those are old-fashioned thing, which is say that you do whatever good in your hand. You know, it is not only your hand. You do what is good for everybody. You know, in your hand, in your colleague's hand. You can't do what is good in my hand. I do this because this is good in my hand. That should not go. It has to match with the current recent advances. There are people who say that open ACL reconstruction is good in my hand. So you think that we should promote open ACL reconstruction? So these things, has to be matched with the current literature as well. That is
Thank you, sir. We have not heard from our one of our seniors, Sudeep sir. Sudeep sir, can you come in for any comments?
Hello, namaste. I sorry joined late because of some other issues. I think most of the things has been already discussed. So there is nothing much to add, but for my opinion, I always prefer the hamstring tendon. It has given me best of the result, and very few cases only I have to go for the BPTB. And multi-ligamentous, then I choose from the peroneus longus, but there are very few cases of multi-ligamentous I'm doing. The primary is my hamstring is my working house.
Okay, thank you, sir. So we have discussed with that. This has been an extensive discussion. Sadly, we didn't discuss the most commonly used tendon, the hamstring tendon. This will be covered in next webinar. So I would like to request our president, Dr. Ishwar Pradhan, to give his closing remarks before we close. Thank you, sir.
Am I audible? Yeah. Thank you, Vivek. All guys, it's nice to have you here. See all of your faces. We had a very nice discussion, more than two hours. It's 11:18 now. Well, as we started this for the younger guys, harvesting a graft for your ACL reconstruction is, I think, when you are starting to do ACLR, is the most important thing that needs to be learned and done well, and perfected, so that the later part of the surgery, making tunnels and just attaching, is not that difficult. The only option we have in our country so far is autograft, and all our experts dealt in depth and in wide about all those things, except the hamstring, which I think I'll have another idea for that. Graft harvest autografts, which was very elaborately discussed, and all of us agree that hamstring is the graft of choice in most of the cases. But of course, there are certain indications for other graft like BPTBs when you want to do it for a sports person, and then you have other tendons that are coming up like the peroneus longus and quads tendon, which might be useful for, is going to be useful when we are dealing with multi-ligament injuries. And one thing I would just like to add here was that it stuck to my head, like when I was attending this Bangladesh seminar, Rajiv had invited that some of the person in Bangladesh were using ACL, we are using peroneus longus as a primary graft for all those young ladies, short ladies who have had, in Dhaka, there are so much of scooters, and they were doing a study there. This is, I found, quite logical. We are also facing the same problem in our ladies population who are short. So there might be an option to, follow up that scientifically, do a research that maybe in the younger girls, ladies, we see a lot of scooty accidents, that is a different mechanism of injury. And the option of allograft, Amit did brought it out here, but we shouldn't be that lagging. In the country now, there are centers who are doing organ transplants, the kidney transplants and liver plants. And maybe we should try to link up and try to bring out allograft from the cadavers. If they are taking out cornea from the eyes, it might be a possibility maybe in the long run, in the future. This is what we have to
exactly, sir. There are two things which I feel that the modern medicine orthopedics is lacking now, despite this immense advances which we have made, is allograft and bone banks. Those are two things orthopedics has not addressed in Nepal.
Yes.
Apart from that, we have immensely moved ahead in technique, everything. Yes. But we haven't got the recent advances, which is easily available to us. We are not talking about the big two, even this meniscal transplant. You don't have a future unless you have it.
Yeah, in the future, that was what I was leading to. Bone bank, and then maybe tendon grafts, and then tendon allografts, and then at the ultimate, meniscal transplant. This is the future that lies, and we, as a team, as a people working together, you are all leaders here. I mean, not me, you are all leaders here. So we should strive towards that. And I'm very hopeful for whatever I see here now with all the younger guys, all the people here. I'm here just to lead. I do nothing here. Besides that, quads tendon, I wanted to point out, I told also, and Amit was stressing that we need anatomical study to really see where the tendons, where the layers of the tendon lie, and then we will be more scientifically supported, and then we can go on with that. I need not say anything about peroneus longus. Amit had a very nice presentation, and everything was there. All the pros and cons and all the controversies were there. And I'm very hopeful. What Amit showed, that MRI studies were also done to show the regrowth of peroneus longus. My concept is like, in our country, most of the patients we treat are normal people, and these people are running around flat-footed, they have a flat foot, pes planus, and they are just going on normally. So what is the disadvantage of taking out the peroneus longus from there? I might be wrong, but it's a good thing. So with that, I think we should conclude. We have taken a lot of time. I just wanted to put this idea, since we did not discuss about hamstring, like hamstring is, we all agree, is the most important graft we must learn, the younger guys should learn to take out. Maybe we should have a discussion on hamstring separately. There are centers, at my center, Amit and Nagmani and Vivek are doing it one technique, and maybe Rajiv is taking out hamstring in a different way, and others in the teaching hospital, or maybe senior guys like Dr. Sudeep are doing. We definitely have a little bit of difference in taking out hamstring graft, So maybe we should have one seminar, one webinar in each of our, institute, how we take it out, so that we can discuss the pros and cons, we can have a healthy discussion. I propose that to Sailaj is not here, but I think that would be a good idea in the scientific discussion for our, oncoming webinars. So with that, I think I should stop here. Have a nice Saturday. It was very interesting today. The situation out of the house, out of your gate is very, 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 scary. Guys, please take care of yourself. Protect yourself. The doctors and the nurses and the paramedics are coming down. We don't want to hear one of our members, becoming the next victim. Please take care. Have a nice Saturday, and we'll meet again. Okay? Goodbye.
Goodbye, sir.